So good afternoon, everyone here in the US, and good evening for folks who are joining us from Europe or Asia. It's a pleasure to welcome you all. This is the last session of the NSF-sponsored workshop that focuses on trying to understand the interaction between modelers and policymakers in the context of the pandemic. And we have a very interesting session. And the plan is that for next 1.5 hours or so, we'll engage these folks in a very lively conversation. So we've organized this session slightly differently. In the first half of the session, we'll have 3 15-minute discussions. Each discussion will be between a public health official and a modeler. And the folks have worked together in each case during the pandemic. We've also tried to cover 3 scales. The first is at the level of a hospital, and some part of it is at the level of a state. The second discussion is at the level of a city, and then we go to the level of a state. In that case, it's Virginia. And after the presentations are done or discussions are done, which is about 45 minutes from now, we will invite our guests back, and then Simon and myself will moderate the session with questions from us, but more importantly, questions from folks who are online. We have requested everybody online to try and pose the questions on the chat, and we'll pick them up, and we'll try and pick up as many questions as possible. Although the session technically ends at 3:30, if the panelists are willing to stay for a few more minutes, all the other sessions have run a few minutes over, but that's something we can decide sort of real time. But with that, Simon, if you have no specific introductory remarks, let me go ahead and start.
Please get us underway.
Okay, so our first sort of a modeler and a public health official group is Eili Klein and Kenneth Bellian. Eili Klein is an associate professor of emergency medicine at the Johns Hopkins University, and also a senior fellow at the One Health Trust. His research focuses on the role of individuals in the spread of infectious diseases. This area of research sits at the nexus of economics and epidemiology, and is premised on the idea of incorporating incentives for healthy behavior and attendant behavioral responses into an epidemiological context to better understand how diseases are transmitted. During the course of this pandemic, he worked very closely with Kenneth Bellian, who is the principal and chief of clinical strategy at Jensen Partners. He provides clients with physician executive perspective and a deep understanding of the complex challenges that exist in the healthcare arena, as well as opportunities which avail themselves to deliver disruptive technologies. Alongside many impactful projects, he was embedded with folks in the state on their pandemic planning response team. So if you have any questions, again, place them on the chat. We'll take them after all the 3 discussions are done. So over to you, Eili and Ken.
All right, thank you, Madhav. Thank you, Simon. Really happy to be here, and really excited to talk with Ken. I'm going to try to treat this a little bit like a conversation. The 2 of us did actually spend quite a bit of time on the phone together at points during the pandemic. And I think he offers a unique perspective. One of the reasons that I sort of, I thought about several different people to potentially invite here. And I think Ken brings a unique perspective because while he doesn't actually work at the health department, he was working closely with them and can potentially provide a little more unvarnished view of some of the issues that I think we had in terms of how coordinated modeling worked within the state. So just briefly, how I got involved in this is actually, working specifically in terms of the role with the state and with the hospital was a little bit random, I guess, in some sense. I mean, obviously, we had funding through the CDC MIND project to do modeling of healthcare associated infections. And we were working on that stuff. And then COVID sort of came, started showing up in China and then Italy. And so at the time, we basically, assumed there was going to be spread here and built a model specifically that was targeted at decision-making that I thought would be super important, which is sort of the number of hospitalizations, right? Since I work at a hospital, having sort of an understanding of like, what are we going to see at the, particularly in the ED, because that's going to be sort of the front door. Many people are going to walk in, but also, just at sort of a state level, where are people going to go? And so we had access to data from the state level of where people who had respiratory infections in the past, likely which hospital you typically went to. So we were able to basically take a geographic model, which was an individual-based model, and assess the likelihood as the pandemic was sweeping through the population, which hospital people would go to. And so initially this was targeted, and the models were specifically, so I would run the model and then build some slides, and it was specifically those slides were going to the ED leadership, and then they shared those slides with people at the hospital leadership. And so suddenly I was in meetings with people at the hospital leadership almost weekly, where they were making decisions about things like how many, not just how many cases are we going to see, but should we be considering turning on or turning this unit into a new ICU unit. So that was like sort of the big decisions that were sort of being made at the hospital level that these models were in part informing, which was sort of the suggestion of, how many cases are we going to see, and do we need more ICU units, and when are we going to need those ICU units? And I don't know exactly how it happened. I was trying to actually find it in my emails, but I guess those models were then shared. So it was I would basically create a PowerPoint slides with here's the latest data and here's the latest projections from the models. And I guess somebody shared those with people at the state level. And suddenly I started getting calls from people at the state level with hey, can you model this additional thing? What if we close schools? What if we open schools? So that was a little bit surprising, and then sort of, there's a lot of stuff that had to sort of, again, sort of not being prepared for all of these discussions and not being in the room with where they were making these decisions. It was a little bit reactive. So it was a little opaque to me what was sort of happening at the state level and what was driving those decisions. Although obviously much of it was sort of in the ether. So we attempted to try to predict in some sense what people were going to ask questions for and try to retrofit the model to sort of deal with those questions ahead of time. But obviously some of it was just reactive, and we weren't always certain how those models and these results are actually being used to set policy. We would just send out the slides, and occasionally we would get information. And I think from my perspective, and then I'll toss this to Ken to sort of get his perspective on how the models were being viewed from the state level and being used for decision-making within the state level, that there were sort of three main gaps and or questions that I had, right? For me, the first major problem with modeling and what it was being used for is that there are different levels of decision makers. So what was necessary and useful at the hospital level might not have been as useful or informative at the state level or at the county level. And there was, a lot of differences in terms of what people wanted, right? Like the number of hospitalizations. And we would get calls from other hospitals that wanted the hospital level data, because we weren't providing the hospital level data in the aggregate slides to the state. But we had this hospital level data for every hospital, our predictions for what hospitals were most likely to get cases in the next several weeks or the next several months. The second is that, obviously the fog of a pandemic, similar to somewhat the fog of war, creates this challenges in trying to streamline data, right? So we were running these models, it creates huge amounts of data, huge amounts of predictions. How do you streamline that data into something that was useful and could be packaged up and sent around to people in a way that was that answered the questions that they were trying to ask us, or help inform decisions that they were trying to make. And then the third is, I think, sort of how do we use these models going forward into the future? I mean, obviously, there was a lot of questions about how to build them and get them running in the short term. And some people had things that were working, some people have built new things. But, typically we've often used models primarily for understanding questions, not so much for forecasting in the space of disease modeling, right? And this question of how do we transform into being something that's useful in a forecast manner in a in a time frame and a scale that is useful, right? I mean, I think it's often compared in many cases to the way we model, the way forecasting for the weather works. But realistically, weather forecasts past 14 days, once you start heading into that stochasticity, there's a lot of the uncertainty becomes so large that those models tend to become largely, unmanageable or with levels of uncertainty that are completely useless to for making decisions. Now, the question, of course, is, what is the right time frame that we want to have models be useful for, and that is a question that is of importance. And the second is, what is the geographic measure that is useful, right? And that might be different at the U.S. level, where policies made at the CDC, versus the county level or the hospital level. And I think the other point is that forecast models in and of themselves, and this was a challenge we had during the pandemic, is that they're inherently not well aligned with the incentives in academia, which are publishing and all these other things. And it's typically hard to publish on a forecast model that, when the forecast, by the time you get that paper published, the forecast is months old, if you're lucky, maybe years old. And then people are judging on how well your forecast did, which was probably poor, because if we could do really good forecasting, I'd probably be a lot richer. So anyway, so we saw, there's, to me, I guess the big questions are, a lot of it is sort of opaque, and how our interactions with the modeling that we were doing ended up informing decisions. And I'm going to leave some of that to Ken now.
Eili, thanks, and thanks for inviting me. I think one of the things that's interesting is sort of how we got to know each other, which was right at the very beginning. Everybody was clamoring for data, and we had been engaged with the state, as you mentioned earlier. My role is, I'm an otolaryngologist by training, and been in hospital administration for a number of years, and we do strategic planning efforts for states, hospital corporations. And we had been working with Maryland, and just they rolled right into COVID. I mean, we were presenting our data and findings to the governor the week the first case was identified. So very quickly it said, can you help with planning efforts? And so we jumped in really de facto to be the state's data team, to help be the interpreter or translator for them. They had a number of, early on, there was no data. And the state is, not dissimilar to a lot of other states and other areas. The data was disparate if you were lucky to find it. It was hard to find the owner who could manage it in a meaningful way. And then to try to aggregate it, there were no data lakes. And so we became the de facto data team. And I think Cliff and others introduced us to each other, and we saw that. And I do agree with you. I think that there was a tremendous amount of efforts. And I sort of liken it to the talks that people give on meta leadership. Everybody was trying to do the right thing, but they were kind of in their own silo. And so sometimes there wasn't always that communication. But what we were able to do is to try to identify, as you mentioned, who are the stakeholders, what are they trying to do, what problems are they trying to solve, or questions are they going to answer. I do have a few slides. Let me see if they come up here, if I can share them. Can you guys see the slides?
Yep.
Yeah.
Okay, so, and I think one of the key things is, running through, do we have a shared vision of what's the modeling for, what's the data that we need, and how were the models, how did we help the state leverage the use of modeling, the ability to estimate or forecast, and what were some of the areas, just to highlight a few areas, the way we used them. I mean, we were down into the weeds of if we needed to add additional bed capacity, as Eili was mentioning, in a unit, we were helping people model based on his models, how many syringes they actually needed to buy and to whom and to when and lead time. So we got pretty granular. And then really, I think understanding that stakeholder, especially the person in the policy seat, of how they're trying to think about preparedness moving forward and what can we leave behind. And so, I always go back to a little bit of what question or problem was the stakeholder you're working with trying to solve. Because I think the key thing is, as you mentioned, really alignment. There's a lot of things that people on this call can do, and they do a lot of wonderful things. But are we providing them with really relevant information? Are we providing them something which is really insightful? Did we get some conclusions or insights, or some fresh perspective? And more important, is it really timely? So, I mean, the fact that, as a physician, a surgeon, I can tell you that something's going to happen, but if it's way before time or after time, then that doesn't seem to be appropriate. And is there really an action attached to that, right? At the end of the day, the Secretary of Health or the governor were really interested in trying to come up with a policy, or, as you mentioned, some operational. How many beds do you bring online? Are those beds ICU? What's your testing program? What's your reopening strategy? And so we spent a lot of time trying to help bridge that gap from the modelers, the data scientists, to the various decision makers. When I think through it, we kind of broke it down, thinking that early on there was no data. And in that regard, there were no models that we could work off of. And this was literally at the very beginning. So the strengths in that was that people had to rely on their plans that already existed. The weakness is really there was a lot of variability in their response efforts, right? It wasn't COVID focused, it based on historical responses. And again, it was very fragmented. And then I would say, again, if we do an after action plan, state was late to the game, right? You guys were ahead, and a lot of the systems were ahead, and same with some of the local health departments. So again, the state now, as a result of that, has built a data lake, a data team, data scientists that they're hiring. So they realize the value of that to try to work with collaborators like yourself. And then once we started to get to that formative period where we did have some data, it was great because we're all working off the same models, same variables. So there was some shared vision. The problem again was that there were a lot of gaps in data. There were a lot of challenges with sharing data, finding data, cleansing data. And so there wasn't really a cohesive approach, but it did allow, as a state, we were able to start to coordinate with, for example, nursing homes or Hopkins Health System or University of Maryland system, or some of the other individual groups. And so you started to have more of a unified approach. The downside to that, we were all working off of the same variables, so it became more difficult to try to personalize your approach. So as we moved more and more to more elegant models that started to be more personalized, you started looking at a subset of variables, which would really help. I know often we would get models from various modelers, and our team would around something specific. So just this past winter, right? RSV, influenza, other respiratory illnesses. What's the potential impact of that on capacity? How do we start to integrate that? How do we look at it from a past performance standpoint? And so with historical data, we could start to look at which models were performing better and why. But then the state, I think, struggled quite a bit with information overload. There was actually too much information. And as a result of that, part of our job was to sift through it and create meta models or ensembles. And ultimately, at the end of the day, where we are today, which is really being able to be more dynamic and nimble and flexible, being predictive and prescriptive. An example of how we use the work that Eili and other teams provided was, this is from January of 21, December, January, February timeframe, where we're actually going through and have a spreadsheet and looking at all the various reopening strategies. So we're looking at, let's say, restaurants or places of worship or youth sports. And, up to what capacity would you open that up? Would it be 25%, 100%, 50%? We're then trying to grade on a probability based on various risk determinants. What would the likelihood of potential spread for COVID be And then in this instance, we were looking at it from an economic impact, right? The governor was very interested in trying to get the economy open as quickly as possible. And so really trying to determine, in a given instance, what's your likelihood of exposure at a given place, let's say place of worship, or if I'm going to get my hair cut or going to the gym, how many contacts am I coming in touch with? What's the likelihood of people being vaccinated? Those were all sort of the risks. And then what would be some of the mitigations? And ultimately, at the end, providing them with some high-level summaries of how risky their strategies or policy implementations look like, right? In this instance, this is really looking at a matrix comparing, the specific risk of COVID opening that area and the economic impact. And so the sweet spot is really in the lower left hand, which is, the greatest impact, the least amount of risk of COVID spread when you open, let's say, retail, or in the instance of Maryland, we have some casinos. So again, our role had been to take a lot of the data that you had been providing and trying to help them actualize it, understand it, and actualize it. Because for a number of people, they needed high-level summary. The other part that I think people started to realize is that there is just sort of a baseline level of cost for preparedness, which is a sunk cost. And that needs to just be assumed. But depending on part of our role and part of the roles that we use the models with is depending on who you're working with, their risk tolerance is different. If they're very, very risk averse, the cost is just tremendous, right? You're up on the, way far to the left on this optimization curve. But if they're, much more of a risk taker, then the cost and the allocation of those resources is different. And so again, it became important for us to understand what their risk tolerance was. And that changed depending on what activity we were talking about. Was it available hospital beds at the beginning of the pandemic when we thought we were going to get 6,000 patients? Or is that around, an urgent care strategy that might be used in the event that there was an outbreak in a nursing home? And so we had to then align what modeling efforts were going on to try to match that risk tolerance. And then, the way I guess my economics background, I'm an economics major undergrad and a business background, is everything seems to come to supply and demand. And right, at the end of the day, the output of the model is a forecast or an estimate of some demand for something, right? There's a number of cases, a number of deaths, and that's some resource. And so we worked with the various people in the state to try to help them understand, how do you get to that equilibrium, right? They're trying to match up whatever resources or supplies are needed to match that demand. But as you mentioned, the lead time, depending on how long it takes for us to activate or deploy those resources, that becomes critical in what that zone of uncertainty is. And as you start to have a much longer lead time, that zone gets wider and wider. And what model would you use, and does it pair up, and what footnotes do you need to do? And so we would help them try to optimize what's the appropriate modeling to minimize that zone of uncertainty, right? Either I overspend and I have a bunch of costs attached to a response to a pandemic effort, or I underspend and I have people who aren't able to get the treatment that they need. And so those are kind of a couple of examples of how we worked with the state to help them start to interpret and apply models. So I'll stop there.
Thanks so much, Eili and Ken. Eili, if it's okay, we can move on to the next group and then come back to you both to the part of the broader discussion.
Yep.
So great, thanks. So we now will move to Lauren and Mark. They worked very closely in Texas at the city level. And let me introduce both of them first, and then we'll hand the floor to them. So it's a pleasure to introduce Lauren. Of course, I know her for a long time. She's a professor in the departments of integrative biology and statistics and data science, and the director of the UT Austin COVID-19 Modeling Consortium. She's been a pioneer in the field of network epidemiology and the application of machine learning to improve outbreak detection, forecasting, and control. Professor Meyers leads an interdisciplinary team of scientists, engineers, and public health experts in uncovering the social and biological drivers of epidemics and building practical tools for the CDC and other global health agencies to track and mitigate emerging viral threats. During the height of the pandemic, she worked very closely with Mark Escott, who is the Chief Medical Officer and the EMS Systems Medical Director for the City of Austin and Travis County, the Texas Department of Public Health, and Texas Division of Emergency Management. Now, Mark has also served as Interim Medical Director and Health Authority for Austin Public Health. He has academic appointments as Clinical Assistant Professor in the Division of Emergency Medicine at UT Austin Medical School, and also as a Senior Lecturer in Medicine and Public Health at Flinders University in Adelaide, Australia. Dr. Escott currently serves as the immediate past chair of the section of EMS and pre-hospital medicine of the American College of Emergency Physicians. So over to you, Lauren and Mark.
Thank you so much. Thanks, Madhav, for having us here. And Simon, we're really excited to be part of this amazing panel. And hello to all the familiar names and faces out there. It's great to be with you guys, at least virtually. I'm going to start and give some slides and tell sort of my side of the story of what it was like to be a scientist and modeler involved in Austin's task force that was responsible for responding to the pandemic. And then I'm excited to hear Mark's perspective on the same lived experience. I'll start by saying that, I think Eili and Kenneth mentioned some of the challenges that a lot of us have faced over the years when we try to interface with the decision makers, the public health agencies. I think you mentioned, sometimes it's sort of opaque. We're doing these models, we're being asked to do some calculations, and we don't really know why. We don't see how they're translated in decision making, and the decisions don't really align with the graphs we sent them. So, and I think Ken, you mentioned the sort of siloed nature of some of these efforts, where we're doing our things up in the ivory tower and the hospitals are doing their thing and public health are doing their thing. And I think in my opinion, the Austin story, COVID response story, is an exception to that. I mean, I think it really is a great case study for just an effective, multifaceted collaborative response. And I do have a few slides, and I'm going to take you on a whirlwind tour of what went down in Austin from my perspective. So here's Austin. These pictures reflect Austin in many words, but anyway, I was fortunate to serve on what I think is a pretty unique task force that collectively governed the COVID response for the city, which is the 8th largest metropolitan area in the country. I think, we were well over 2 million people when COVID started spreading. And I think this task force, and I don't know what they all look like around the country, but I think from what I've heard is sort of unique in 3 different ways. It's unique in its composition, and I'll tell you who was on it. And it was unique in how we consistently met for 2 years, sometimes 3 or 4 times a week, sometimes once or twice, depending on how heated the situation was. And I think we were really, really unique in the sort of collaborative and evidence-based approach we took to making decisions on a daily basis. And Mark can tell you more about how this task force was put together. I was I think, one of the last additions to it. And I was looped in by the then dean of our medical school, Clay Johnston, who knew of the kind of work I did and brought me in to provide some expertise and model support. So the members of the task force included our elected officials, our city mayor, and our county judge. And in Texas, county judges are really the seat of authority for public health and emergency responses. Our public health leadership, including Mark, who's down there on the lower left, he really led the charge in so many ways in some of the most difficult situations I imagine he ever faced in his career. We had executives of our 3 major hospital systems that serve the metropolitan area, and I believe all of our hospitals are for profit. So there were sometimes not perfectly aligned interests in between public health and the hospitals, and then clinicians and researchers from UT, including myself. And so I feel, of course, I never wanted the kind of work we do to actually needed to fight a pandemic, right? None of us ever wanted to face anything like this in our careers, but we were worried that we would. And I mean, I'm really feel fortunate that we had an opportunity through this task force to bring our expertise and bring our models to bear on these very life and death and challenging matters. And when I say kind of bring the science and modeling, this was not by any stretch work that I did alone. This was the work of dozens of people who collectively banded together under a consortium I founded in early March called the UT COVID-19 Modeling Consortium. And I just reached out to colleagues across the university, across the world. And it was just basically a daily Zoom so we could all get together and figure out who had time and expertise to tackle the different requests that were coming our way. And, in February and March of 2020, I certainly didn't have enough grant funding to do the amount of work and hire the postdocs and everything that was needed to respond to all of these requests. And that is something that I think got a little bit better, as time went on. But, for future threats like this, future emergencies, we need to have mechanisms so that researchers like us can rapidly ramp up and provide the kind of support that's being requested. And we were fortunate to have a local company provide some of that initial funding so that we could support the city and others and the response. Okay, so the task force, thanks really to the leadership, to Mark, to the mayor, led with science from day one, led with science both in decision-making and communicating with the public to help people understand the risks, to help understand the motivations for the different policy decisions, and to help cultivate pro-social, pro-health behavior, adherence to guidelines. So this is a screenshot from one of our local TV stations, our local NBC station, right when the first stay home work safe measure was declared in late March 2020. And what you see here is a stylized version of one of our first sets of scenario projections that informed the decision to shut down. And the task force asked if we would go public with this and make sort of a more interpretable version. What you see there, you guys have all seen graphs like this, but the blue is showing where we're safely under hospital capacity. And this was meant to show if we don't do something drastic, we're going to quickly exceed hospital capacity. So we responded to a lot of different requests, sometimes multiple a week, sometimes, once a month. But we did things like make calculations to help the city figure out excess risk to the construction workforce, which remained open when the rest of the city slowed down or shut down. We helped the city, we did calculations to help anticipate the burden in population experiencing homelessness so that the city could figure out how many hotel rooms to procure as isolation facilities. So we made some projections about what it would look like in a surge, and that led to, I think, procuring about 200 rooms. We also at UT made our own dashboards. And I think, like many of you who end up with dashboards, it wasn't like we invented like some use case. These were really born out of coming every week to the task force and showing the same PowerPoint slides again and again and realizing they want this data every day, right? And so instead of coming and regenerating, we'll build a dashboard. And fortunately, the Texas Advanced Computing Center, our supercomputing center, and affiliated with UT, had the manpower and the expertise to very rapidly build the front end so people could see and interact with our models. So those are dashboards that were forecasting ICU demand and hospital bed demand in the area and estimating the growth rate of the virus in the city at the time. We had other dashboards that were looking at spatial disparities in burden and access to vaccines. And then another that came out of conversations with schools to help schools anticipate risks of introductions as they opened up as a function of where they were in the country and how many kids were in the school. A lot of the analyses we did have never seen the light of day in terms of peer-reviewed publications, but for many of them, I think there are over 40 of these, we issued rapid reports. These are self-published reports on our website. And they put in sort of prose form some of the discussions that we had with the city or with other partners that we were doing analyses for. And the reason to kind of semi-publish them was, part so that they would just have access to it sometimes and when they wanted it. And also partly because, at least in Austin, sometimes the local authorities would refer to our analyses or actually show our graphs on TV. And so they wanted some kind of documentation for the public. But I think the thing I'll spend an extra minute on is what I think is one of the real keys to Austin's success and one of the really impactful sets of analyses we did. And that was the development and maintenance of a staged alert system that guided Austin's response for about 2 years. And you've seen alert systems like this, but ours was sort of really grounded in a pretty rigorous modeling science. And I'll talk a little more about that in a second, but the way it works is we were tracking one indicator, the 7-day rolling average of new admissions into area hospitals for COVID. So that's the graph you see there. And when we hit different colors, when we hit different thresholds, we either tighten policies or loosen policies as you go, up to red and back down. So part of, I think, the key to our success was the fact that we developed a good system. But the other aspect of it was that our local leadership really went above and beyond in transparently and consistently communicating the policy. These are screenshots of Mark and the mayor and other leaders on TV, on social media, explaining what this system was all about, letting people know, hey, we're heading into orange, please lock down so we never have to hit red. You see in the upper right there, local TV newscasters also trying to explain what's stage 3, what's stage 4. And, by the time we got a year into the pandemic, you talk to people in the streets and everyone would be talking about what color we're in and what are the admissions doing and are we about to hit 39. So it really became part of the fabric of how the whole community kind of tracked risk and responded. So we worked with the city to design this system in April of 2020, and we used models and policy optimization approaches to design a system that achieved 2 specific goals. And so these were goals we actually formalized in our models in order to design the system. One was a public health goal, and it was not to save as many lives as possible. It was actually just to keep our hospitals under capacity. We never wanted the demand for hospital beds and ICUs to exceed our capacity in the region. And then the socioeconomic goal was, while we're preserving capacity, we want to keep things as open as possible. We want to spend as few days as possible in red and, a few days in orange and spend as much of our time down below in green and blue and yellow. And so I won't go into the details, but we built a very detailed compartmental model with lots of structure in it of COVID spreading through the city. And we included in that a staged alert system. And inside the model, we're tracking hospitalizations and changing the alert stage. And the consequence of changing the alert stage of the model meant we were either increasing or decreasing the transmission rate. And then we searched a large policy space, a large set of possible levels for those thresholds. And we solved for, using the supercomputers at TAC, we solved for where we should draw the lines between orange and yellow and red in order to safeguard our hospital system while keeping things as open as possible. So we didn't just run this optimization once. We probably ran it, 50 different times throughout the pandemic as things continue to unfold. Our understanding of the virus changed, our understanding of behavior changed, our hospital capacity changed. And each time we would go back, we would pressure test the system using our model, we would update our assumptions, and we would ask, do we need to change those levelers or not? Things like an increase in hospital capacity, coming close to ICU capacity, lower ICU capacity. When things look bad, we also wanted to know, is there a threshold for when we should pull the trigger on setting up a field hospital in our convention center? Then things changed as new variants emerged and people vaccinated. And sometimes we would redo the analysis and it would say, things look fine, keep using the current stages. Sometimes it would say, okay, we really should raise or lower one of these thresholds. But we'd always ask, do we really need to, is what we have good enough? Is it okay that we didn't raise it by, 3 admissions? Because we also wanted to be as consistent as possible and not in terms of like continue to cultivate public trust in the system. We didn't want to be flip-flopping all the time. So there was sort of what is the optimal in terms of numbers, but then what is the optimal in terms of utility for overall utility as a policy. Okay, so the system mostly worked as designed. It was optimized to keep our ICUs under 200. And we mostly did that, not perfectly, I'll get into that later, but we mostly were able to do that. And we went into 3 periods of stage 5. Those 3 periods of stage 5 were much shorter than the lockdown periods that other cities in Texas faced. And so we also, to some extent, I think, achieved our socioeconomic goals of like minimizing the socioeconomic harms of locking things down. Although we didn't design it specifically to save lives, Austin, I think for a variety of reasons, managed to limit its mortality, or, I think lower its mortality relative to other major cities in Texas. So what you see here is cumulative COVID-19 reported deaths. Travis County is that bottom blue line, and I'm comparing it to 4 other major metropolitan counties in Texas. You can see that this only goes out till summer of 2022, but it's fortunately fairly flat ever since then. But our cumulative mortality rate is less than half the statewide average, considerably lower than all the other major cities in Texas. And when I compare Austin to the nearest size metro areas, we also fared better. And our mortality rate is considerably lower than the US. And there's a lot of things at play, not just the policies and the evidence-based decision-making, but certainly our younger, healthier population than some of these other cities. But certainly that's, that is, I think, some testament to the sort of the quality of the response overall. So with that, I'll hand it over to Mark, and we can hear his perspective on how things went down.
Thanks, Lauren. And I know we're running a little bit behind time, so I'll be brief. First, let me say that as we entered the pandemic, I was supposed to be the health authority for about 6 months, from October to around March, and then the pandemic hit. So I was brand new in this role. As things started to unfold, we initially created an expert panel to make a decision about, at the time, a very important factor. That was our South by Southwest event, which brings about $500 million to the city of Austin. And from that group, we started generating some concepts of, what do we do next after the big decision? And we started to conceptualize this risk-based guidance, or at least a something that we could share with the public that demonstrated risk. But there was some concern about that, right? As Kenneth brought up earlier, is the information going to be timely? Is it actionable? People pointed to the DHS terrorist threat risk and how it was meaningless to everybody. So we started to discuss that, and how do we make this meaningful, right? What specific actions are people going to take? But ultimately, how are we going to make the decision about transitions? Luckily, Dean Clay Johnston introduced me to Lauren, which is basically just an email saying, hey, do you know Lauren Meyers? She is a fantastic modeler for flu, and they're working on COVID. But that introduction was incredibly important for us as a city to really get our heads around this development of policy, which really transitioned from, the flatten the curve strategy to what we were calling at the time the oscillation approach, which was basically, as Lauren described, how do we create a policy which is sustainable over time, that minimizes the impact on the economy, but also avoids that pandemic fatigue that we knew was going to happen. And ultimately, the modeling worked out very well for us, not only to help decide what those trigger points were on the way up and the way down, but also to ensure that we had an effective way to communicate that to the community. The evidence was very clear for them. We have a community that is responsive to science and data, who really it became the language of the community for quite some time. So we're incredibly grateful for that. But there are challenges along the way. One of the challenges I think that we all have to keep in mind is how do we integrate this in the future? Part of the challenge that we had, and certainly other communities had, was the silos between academics and public health and policymakers and emergency management. And ultimately, we have to be speaking the same language in terms of the utility of modeling in order for us to do this different next time. So I'll leave it at that. I look forward to the discussion, and we'll pass it back to our hosts.
Thank you so much, Lauren, Mark, for this absolutely interesting story. I was always very keen to hear how you folks did this. And I must say that we really felt that you folks did an amazing job out there in Austin, and look forward to your reports oftentimes. So with that, let's move to the last discussion. And this is something that we're going to do where the discussion goes back at the state level again. And I'm going to introduce two folks who I know very well in this particular case. Let's start with Bryan Lewis. Bryan Lewis is a research associate professor at the Biocomplexity Institute here at UVA, and a really dear friend of mine for now close to 20 years. It's hard to imagine, but that's how long I know Bryan. Dr. Bryan Lewis has spent past 2 decades crafting, analyzing, and communicating the results of computational epidemiological models to policymakers and scientific community. He was lucky to cut his teeth as a PhD student at Virginia Tech in the Meyers project, and was involved in planning for hypothetical influenza pandemic and then a very real response to the actual 2009 pandemic. In the years that followed, he worked to develop new modeling techniques and supported federal responses to the Ebola outbreak in West Africa, as well as myriad of other pandemic threats emerging around the world, including MERS, Zika, cholera outbreaks, etc. During the COVID-19 pandemic, he helped lead a team to support the Commonwealth of Virginia, as well as federal authorities, including the DoD, CDC, and NIH, through a variety of modeling and forecasting efforts, as well as many ad hoc analysis. After leading Virginia's forecasting efforts during this time, we met actually Justin Crow as a part of the state response effort. And Justin Crow is the person who launched the Foresight and Analytics Unit at Virginia Department of Health, Office of Emergency Preparedness, and now leads the unit full-time. He has been somebody we've worked with very closely now for close to 3 years, and is responsible for leading much of the work on the modeling side within the Commonwealth. Justin has performed public health research and analysis for the Commonwealth for the last 12 years, including as a deputy director of the Virginia Health Care Workforce Data Center and the director of VDH's Division of Social Epidemiology. He has worked in the forecasting area for over 8 years, beginning as a volunteer and then becoming a super forecaster within the Good Judgment Project. So Bryan and Justin, over to you.
Thanks, Madhav, and everyone for having us here. It's great to hear Lauren and Mark's and Ken and Eili's experience, and I'm glad to sort of share some of that. I think, Justin, you were maybe going to start off with the initial anecdote of how we initially got together and where the engagement sort of started off, and some of the actual use of modeling support early in the pandemic, much like what Lauren was just intimating about. And then I was also going to describe some of the process in which we as modelers engaged with and communicated across the different levels and across the different departments at VDH and other areas of the Virginia government. But I'll leave it to Justin to sort of start off with the initial engagement.
Great. Yeah. I think it's always a good idea to start off talking about our relationship with UVA, with the Biocomplexity Institute, with Madhav and Bryan, talking about really one of our very early successes during the pandemic. And I'm sure y'all, a couple of folks have mentioned this already, a lot of the uncertainty that was happening early in March, April 2020 in a lot of areas. We were seeing what was happening in China with them throwing up field hospitals. Italy's more modern hospital system was getting overwhelmed. There was, talk of sending the USS up Comfort to New York. They even talk of quarantining New York at a couple of points. So there was a lot of uncertainty and a lot of worry at that time. And policymakers were definitely very desperate for information and for data and for information on what was coming. So they're reaching out to wherever they could get it. And in Virginia, it was our own internal folks and then some external folks as well. But our capacity, of course, was limited. So we did have a presentation, an internal presentation early in April 2020 on April 7th that did pull from some COVID-19 models, some very early ones that were public. And I won't name where they came from, but from universities here in the US. And so I'll just tell you what those models said was going to happen in Virginia with COVID-19. The first one said we would have a peak in mid-April 2020 with about 2,800 hospitalizations as the peak. The other one had a peak in mid-May 2020, about a month later, and it estimated about 38,000 hospitalizations. So 13 times more hospitalizations in a month later. So a huge difference. So a lot of uncertainty regarding those models. So credit to our policymakers and leaders at the time. They did dive in and try to improve our modeling capability. So we did an extensive search. I came on a little after that, so I'm not sure what all was involved in that search, but ended up contracting with Carter Price from Rand Corporation and of course the UVA Biocomplexity Institute to really provide some guidance on interpreting these models and understanding the models. And then also the Biocomplexity Institute to provide Virginia specific forecasts. And what they really accomplished at that time is, a lot of states, every state, I believe, was in the process of setting up field hospitals, alternative care facilities, as we called them. And what the UVA model and the interpretation provided by the Rand Corporation was that some of the early public health restrictions that we were putting in place at that time were having an impact. So the curve was flattening. So using the modeling, the data coming through, able to demonstrate that, and that we were unlikely to need those field hospitals. But just as importantly as showing that curve flattening, the forecast was that the UVA team, assured us they would be able to provide 6 to 8 weeks notice of our hospital capacity being breached in the state, and should the situation change. So with that, it took about, 3 or 4 weeks to throw up a field hospital. I don't know how they do that, but that was the timeline that we had. We were able to kind of pause those alternate care facilities here in Virginia. A lot of states did end up opening those. I mentioned the USS Comfort. Very few of them actually, served any patients or definitely very few COVID-19 patients. So I always like to point out that that very early success, having that modeling available very early in the pandemic to answer those questions, probably paid for the entire modeling effort after that. So that was the beginning of what's been now an almost 3-year relationship with the UVA Biocomplexity Institute, and we are actually under contract for at least another 1.5 years on some projects. So they've been providing a variety of products. The forecasts that they provide, we do a lot of public reporting of that. Weekly and biweekly stakeholder meetings involves some of our hospital and health systems. A lot of our EPIs throughout the state, and a lot of county, local, and school officials attend those meetings. Even now, we still have at least, usually about 100, a little over 100 people who attend every week. We have several dashboards that have been, like as other folks have mentioned, that provide updates more periodically, more regularly, are available for folks, and then a weekly brief on modeling activities. Our ad hoc analysis, a lot of the questions that come down from policymakers, the UVA team has provided. So queuing and the impact of contact tracing, improving those models. mobile site placement for where we're doing our vaccine rolling and our mobile testing events. And then, supporting tabletop exercises, just some key kind of ad hoc work that the UVA team has done throughout the few years. And I think one of our most notable successes was our ability to really provide, foresight on the coming Delta and Omicron waves, particularly when the vaccination campaign was rolling out and people were thinking about herd immunity. And then in the summer of 2021, cases got really low. So able to foresee Delta coming. And then when the Omicron wave was about to hit, that was one of the few times that we were called up to actually meet with folks in the governor's office and provide modeling information directly. And we were able to really tell them, we're looking at days and weeks here, not weeks or months in the need to respond. So that, I believe, had an impact. And then one of our biggest successes has been really our continuing growth of the partnership beyond COVID-19 and the work that we're continuing to do with the UVA Biocomplexity Institute. And I think we're going to go back and forth a bit, Bryan, so I'll turn it over to you to kind of fill in some gaps there.
Sure. Thanks a lot, Justin. And yeah, I think we were very lucky here in Virginia in many ways, in that we had sort of the right people in the right place to sort of interact with each other, and the way that things sort of evolved over time. I think, we were lucky, although I would also say that luck sometimes favors the prepared, right? And so I think we also owe a debt of gratitude to some of the, research projects we've done over the years. We've gotten a lot of support from the CDC. I mean, I think Lauren and I were both on the flu code developing our metapopulation models of influenza, seasonal and pandemic sort of response for the CDC. And we're sitting in, a conference room down there in Atlanta in the December preceding all of this, right, when COVID was just a sort of the early chimes of that. And so having those models on the shelf to then be modified, and also having had the experience of participating in a variety of different forecasting challenges or other research projects like Meyers, et cetera, where we were able to interact with different parts of the government to understand how those models get ingested and what kinds of messages are appropriate for different kinds of folks. I think Ken had alluded to that earlier. It's like, what problem are you trying to solve really dictates how you might structure a model, or how you at least interpret the results of it, or how you might parameterize it or design the scenarios. You don't want to show, school closing stuff to like hospital execs because they don't have as much control over that. But what they can control is maybe some of the way they do their triaging, or at least looking at the lead times they might have under worst case and better case type scenarios. And so just to give you a little flavor of just the rhythm that we had fallen into, we have done, I think, over 120, 150, depending on how you count it, regular updates. For quite a while, it was a weekly cadence we were on, then we switched to a bi-weekly cadence. These generally took the form of sort of doing some initial model updates and or analyses that might have come up from the previous week or previous weeks where certain questions were posed. We would make these sort of updates. They took the form of, I'm sure, the widely beloved amongst everyone, PowerPoint slides. And I thought that was awesome that Lauren and her team were publishing these technical reports. We were providing ours sort of in slide form and keeping those updated regularly as well. And we would brief, Justin and his team, who would also then be the main communicators across the different layers and different departments within the Department of Health there at Virginia. We also had for quite a while a regular meeting. We were meeting with the Secretary of Health and other secretaries of education, et cetera. And so that sort of higher level communication and questions and concerns that they had, because they were also integrating information from a lot of different sources, and they would bring up things that there was no way for us to know, or we had our heads too down in the weeds to really be paying attention to. And so that was always useful qualitative information for either future tweaks that we would make, et cetera. And then we also had a regular meeting that was with local health district EPIs and directors, as well as hospital association folks. And we got a lot of really good qualitative information there from the hospital folks reporting on changes in their census over the last week or two, which were often really nice things that maybe were in the data, but we hadn't really paid enough attention to. And that could sort of bring on new analyses or changes in terms of like the severity index that we were using in our models, and that could keep them up to date, et cetera. And so we'd go through this sort of rhythm of sort of presenting and communicating these results, get questions, see different things. We also participate in a variety of different communities. I'm sure most folks on this call were also off and on at different points, but CDC organized calls, some of the forecasting and the scenario modeling hub groups. Our NSF expeditions group had a really nice seminar series that was going on where we had a lot of different invited speakers come in and provide different angles of the pandemic that maybe hadn't been fully considered in just sort of the week over week, update the model. What's the new scenario going to look like to some of these bigger picture questions? And so all of that sort of synergy sort of helped us communicate these, these model updates. One other aspect I guess I'd like to weigh in on is that we had a lot of tools that we'd already sort of built or had rapidly modified, sort of had been in proto forms prior to the pandemic, and then needs would arise. And so we had an agent-based model, which we were able to use for some of the contact tracing questions that were coming up as VDH was trying to consider how to reallocate their personnel during some of the lag times. Do we want more case investigators or do we want more contact investigators that are following up on the contacts? If you optimize for one, but you have to pull people away from the other, what might yield the most fruit? And so we did, a couple of ad hoc analyses and various different studies of that type over the course of things. For a while, there's a big question about therapeutics. We're taking our projections and turning that into projections on therapeutic uses at different geographic locations across Virginia. And so that was just a variety of the kinds of tasks that we were engaged in over the course of these many years. And again, I sort of I remember this morning, Julia Gog had mentioned something about like nothing really went to plan, but a lot of things happened that weren't ever really planned for, where different individuals in different locations were able to do things that helped really push and make significant contributions to the sort of the control of the pandemic, or at least, the best of that ability. And so I think one other aspect of this is that, as Eisenhower said, plans are useless, but it's also indispensable. And I think that really is, I count myself lucky as having been a part of some of this pandemic planning for a long time. And there was things that occurred during this pandemic that people flat out refused to say would ever even be possible. I think even, Lauren, when we were in that December meeting for flu code, some of the CDC policy folks were saying we would never do work closure. And then here it was in March, everyone's working from home for a really long period of time. And so it's interesting to see how we had planned and thought about, the potential benefit, and that had been demonstrated, even some of these very sort of old papers going back years and years, beginning of my engagement in this community with Midas. And so it was sort of harkened back to. And so I think to some degree, there is a success note here that as much as we would like better data and we'd like these data use agreements to be better, that we should sort of also take note of and sort of celebrate that in some ways we were prepared, even if nothing necessarily went to plan. But because we had been making some of these plans, many of us were in positions that we could sort of chip into. And I think the modeling community was able to contribute reasonably well to the overall response at the local, state, and federal levels. And so that's my little monologue on all of that. And maybe, Justin, if you had anything else you wanted to echo on to, but maybe we can go ahead and move on over to the question and answer phase.
Yeah, I just wanted to kind of, I think, echo a little bit of what you said and a little bit of what folks have said earlier about the need to really educate policymakers and the public about forecasting and the use. I loved what Lauren and the team in Texas did, in Austin did with getting that very clear diagram up there with very clear thresholds, and then having news folks, local news, kind of educate folks. But we did have to spend a lot of time educating folks on the use of forecasts, and this is something that kind of evolved over time as we kind of understood what our limitations were, educating folks on the difference between what a scenario projection is and an actual forecast is, kind of providing some definitions and information on that. So the education aspect of people, I think, is something that we're planning to approach here in the next couple of years as we, hopefully prepare for the next pandemic. Hopefully don't see it, but as we, begin to get folks more used to using these tools when they're needed, especially as, with the state, we have, working in government, we have a different type of turnover. So we have more turnover, I think, and sometimes when you have turnover, it's whole cloth at the leadership level rather than just here and there. So getting that sort of education and language in place to educate folks when these things come up and we need them. So I think that's all I have today, Brian.
Great. Thanks so much, Justin, Brian. Excellent presentation, as always. So we'll move to the second part of the panel, and Simon and myself will hopefully be able to take some questions from the audience. They have posted some already in the chat. Please keep them going. I'll ask the question. Simon, do you want to start with a question?
Yeah, first of all, great presentations, all of them. I have a number of questions to ask, and I don't want to dominate the time, but I'm going to start with Lauren. Lauren, you operated at the city level, but you have a lot of opinions at the state level in Texas. And I'm wondering whether you were able to operate completely independently or there are trade-offs. And of course, there's a federal level too. So how did that work?
Can I plead the fifth? No. We had a lot of autonomy, right? I mean, we might have sort of broken rules about the grants that were supporting our research or, offended the state by helping the city. But there was a lot going on, and, nobody was telling us at the time we couldn't do this kind of modeling or we couldn't have these kinds of conversations. And nobody has told us since that we broke any rules. And, I think like a lot of the scientists who felt like called to duty, right? We've been thinking about these pandemics for our whole careers, and nobody told us what to do actually in the moment. We just had our models. I think a lot of us just like stepped up. We started getting requests right and left. Probably some of you got these early emails from the White House Coronavirus Task Force saying you have 48 hours to predict how many people are going to die in the United States for it to influence policy. And we worked around the clock with our baby models of COVID. And I don't think our projections actually influence policy, but nonetheless, I think, we just stepped up and we did it. And so I had a long history of working with the state of Texas. We'd have a number of projects and contracts with the Texas Department of State Health Services between 2009 H1N1 and COVID to develop models, build decision support tools. But then in the midst of COVID, when things were so politicized in Texas, the governor and the state agency really wanted nothing to do with our models, and ostensibly because we were helping Austin, and there was political divide between the city and the state. So there's a lot that went on. Eventually we got to the point where, even though there was some kind of barrier between us and the state in the first, I'd say, year of the pandemic, at some point we kind of came back together, and they solicited our help in some things that we'd done in the past for them, helping them with surveillance. And then fortunately, I think, Brian mentioned that we were in the middle of a project with the CDC to build pandemic flu models. And so, the CDC did a tremendous job at not only reaching out to our small network of researchers, but just coordinating and connecting all the modeling groups all over the country and all over the world. And they had us all on like 4 calls a week in those first couple months. And it was just kind of a free for all, I think. We would just, each one of us would jump whenever there was like somewhere we could help, or we thought we had the expertise and we could do it quickly.
I get part of my question, actually, I probably phrased not quite right, which is, did the city have the autonomy really to do whatever they wanted without interference from the state?
The answer is a hard no, but I'll let Mark elaborate on that, I think.
Well, I was only sued twice from the Attorney General, so it wasn't that bad. Publicly, there was a great deal of debate between the city and the state in terms of policy and approach. Behind the scenes was much different. I received numerous communications from various state stakeholders saying, keep doing what you're doing. And the political issue was a big challenge, right? To some extent, the Trump administration painted some folks into a box that they could not get out of. So, to some extent, I think the state valued what we were saying because they couldn't, because they were in that box. So I think regardless of what happened publicly, I think there were some benefits of us having that autonomy, the level of autonomy that we did. Our governor, despite the pressure from the federal government, decided to enact a mask mandate in the summer of 2020, which was a bold move at the time when the rest of the Republican governors were not doing that. But that was we had some back channel discussions on how to frame that properly. And ultimately for us in Austin, as well as the rest of the state, because the level of fear and anxiety was so high, even though the state reopened things, the public didn't feel safe to go shopping like they normally did. So the justification we used to the state was it's helpful to the economy if you do a mask mandate, because people then know it's safe for them to do what they normally do. And ultimately that was helpful. One of the things that Lauren didn't mention on the other side of our policy and benefits in terms of lives saved was that the Austin unemployment rate was amongst the lowest of any city in the United States. And that's because we were able to strike that balance. And, thankfully, while there was friction between us and the state, it still allowed us to do what we needed to do.
Thank you. And before I leave you guys, I have one more question, Lauren, which is I was interested in this consortium you put together, and wondering, first of all, I assume you'll sustain that. Would you recommend that other municipalities put something similar into effect, and what level should these be? Should it be at the state level? Should it be at the federal level? How would you organize this?
So the consortium was really just a consortium on the research side of things, right? There was the task force that the city put together, and that is still lives on, but in sort of a different form. It occasionally is talking about mpox or flu or, doing other things, but it's still the same group of stakeholders getting together. And, from my perspective, that seems like a great thing for a large metropolitan area to have and to maintain for whatever comes our way. As far as like the research side, the consortium, I mean, that was an amazing network of scientists that spanned a lot of different disciplines. Half of the people who voluntarily participated in our daily Zooms went back to doing what they did in their day jobs. That you'd call them the armchair epidemiologists, who were great, like modelers from physics or engineering or whatever, who decided they wanted to build an agent-based model. And, they brought a lot to the effort. And they've gone back, and, it sort of has, with attrition, we're much smaller. But I think our field needs that. I think our field needs these interdisciplinary networks that are connected together either virtually or on single campuses, that bring social science together with engineering sciences, with epidemiological sciences, with policy making, all of that stuff. Because, one of the things we all appreciate now is that these are really complex problems, and even the smartest modelers in our field can't possibly think or model in all dimensions. So, I would love to see that sustained, but we need grants and institutional investment for those kinds of things to, withstand the test of time.
Something like that, I think, was part of the motivation for Prepare. So as we write our report, that might be a strong recommendation, Madhav. Yeah. So I want to ask one other question before I turn things over to the chat. And I'm going to direct this at Eili, but it's really a question for all the modelers. But Eili, you made the point of the differences between a model constructed for understanding and a model that's constructed for prediction. And I agree with you. But I want to point out that there are several other uses of models. And in particular, there's models that are developed for management. There are also, I'll just mention now, there are models that you could develop that are basically flight simulators, so that regulators might be able to play with them, and that's different use. But I want to focus in on the prediction versus management, because we've done some work, and I'm sure many other people would show that the limited ability of predictions suggests that an optimal management model might look quite different than a model for prediction. You might, depending on the risk tolerance profiles, you might err on the side of caution. And anyway, it's a different kind of model. Can you comment? And maybe the other modelers will want to too on that.
Sure. And Justin and I had a bunch of conversations. Justin Lessler and I had a bunch of conversations early on, because there was a lot of effort on forecasting, and then they sort of started the scenario modeling hub, which was this concept of the difference between the question of sort of what is going to happen under these circumstances versus sort of we're going to try to predict what's going to happen. And I think the question is probably different in the midst of a pandemic, where there are a lot of choices can be made and a lot of questions. There was a lot of uncertainty about the biology, but there's also a lot of uncertainty about what to do from a public policy standpoint. I think and there you could sort of talk about, well, what if we mandate vaccination? What if we mandate face masks versus other policies, and what is the potential impact there? And that, to me, I think is probably at least a little bit more what I think by what you mean by sort of the management type of model.
What I meant was that, to give you an example, led by a couple of students here, Dylan Morris and Fernando Rosin, we looked at models for when you ought to impose quarantines and when you should take them off, based on what the level of the epidemic was. But and there was an optimal strategy you could devise there. But that depended on your actually knowing what the levels were. And obviously there's a lot of uncertainty as what the levels are. And we showed, or they showed, I should say, because they did most of the work, that if you got it a little bit wrong, the optimal strategy could be catastrophic. And you'd be much better to have a more conservative strategy where you kept the quarantine on longer, for example, and didn't try to depend on exactly knowing. So the management model, which would be designed, and this is, we have a lot of experience with this with fisheries too, would be to optimize some outcome in the face of uncertainty, and that might not rely on excellent prediction. It might rely on basically integrating over a set of scenarios and taking into account that you might be wrong.
Right. No, and I mean, I think, again, the question, I think, depends on what level you're looking at, right? And I think, if you're interested in finding out what's the optimal number of beds we need for an ICU, then your predictions as to how many cases or how many people are going to be walking into the ED in the next 2 weeks are important, but you may want to be on the conservative side because you don't want to run out of beds. But again, this question around forecasting versus management, I think are the whole point, I think, of most of these forecast models is, in theory, to devise what policies you might want to plan for. And I find that most of these forecast models or the forecasting stuff that's done by the CDC have generally been about how well can we predict the peak of flu, for instance, right? That's what all of them were primarily before COVID. And it's still primarily about how accurate can we potentially be over the next week or two for cases. But it's not really telling you who's going to use those models or what they're going to be used for, or how they're going to actually influence decision making. Whereas, the scenario modeling hub, which was specifically looking at types of scenarios, was one way of, potentially saying, well, if we increase the fraction of people who are going to be under the mandate for vaccination, how does that change things? Or you could, again, you could flip it around and say, what is the timing and put it more in a management way. And I think those models are probably more useful from a policy standpoint than these forecast models.
Yeah, So let me turn things over to the question Steve Eubank asked, question for the public health panelists, which is, what are the biggest hurdles to deciding to consult academic modelers to figuring out who they are and working with them? So maybe any of the public health people could jump in here. You don't have to raise your hand to speak up.
I'm happy to start, Simon. So luckily, the finding out who they are was easy because I was introduced, as I said earlier, and again, luckily, we had Lauren and her team right here in Austin, so it was an easy connection. I will say that there was some significant hesitation on the public health side to bring in academics. And I see this in other public health officials I talk to. Well, those academic people, they're out of touch with reality. They don't know how things really work. So overcoming that issue was a challenge. I think the other big challenge was in creating a system, a data input that could be utilized effectively to build the models. We didn't have a way to track hospitalizations. We didn't have a way to track ICU admissions. We didn't have a way to track hospitalized patients with COVID. And we had, a relatively archaic method of tracking cases, right? We get faxes from labs, which seemed ridiculous at the time in 2020. So we had to, work with our stakeholders, as Lauren mentioned, our hospital CEOs, to create those data streams. It started out manual, and then it was an automated process, but that took a lot of convincing. It took a threat of legal action in one circumstance, but ultimately, state law allowed us to demand that information, and we got it. So a significant number of challenges in bringing in the academics, but I think all of it's related to a lack of familiarity prior to the disaster, right? We try to bring these groups together during a disaster, and in the midst of that threat, all they see is threat, right? Bringing in new partners that you don't know, that you haven't worked with, is seen as a threat also. So maintaining and building those relationships prior to disaster is really helpful, I think, to ensure that we can regularly use and people understand the utility of modeling the future.
Thank you.
This is Ken. I would say, Mark, our experience is a little different. We had the pleasure of working with 3 states throughout COVID. And maybe ours is a little different because I was the one doing a lot of the reaching out and bridging those relationships. But I think some of it was the tyranny of the immediacy, right? So you were able to connect up with the various modelers. Everybody was more than willing to share data and their expertise, but you moved to the next fire. And so sometimes that relationship, over time just deteriorated. You didn't continue to cultivate it. But I agree with you. I think that our experience was people didn't realize how valuable, or they didn't know what they didn't know. And so I think now we really, people have done a great job of understanding the value of modeling and data and different types of data. As a former hospital executive, it was interesting to talk to some of the state epidemiologists who were like, why do you want my data to predict hospital beds, right? I just didn't know the value of that epidemiologic data could be used operationally. So I think a lot of the groundwork that Lauren, you were describing, has already been done. And I hope we do keep it moving forward. I've always been amazed that as a hospital executive, and we always set up these incident command centers during an event, but where's that ongoing dashboard that helps me say, did I win today? If not, why not? And what am I going to do differently tomorrow to win? And so I think I know that we've left behind several software applications for the state of Maryland that are beyond COVID. We've already entered in a bunch of non-COVID data so that they now have the flexibility to determine cancer screening or vaccination. So it's no longer COVID vaccinations, but it's childhood. And, but yeah, I had a little different experience around the reluctance, but again, different states,
Yeah.
different politics.
Justin, do you have a different experience yet?
Yeah, well, I think I kind of agree with both of those takes. We think we were very fortunate when COVID hit to have an innovative respiratory disease coordinator here in Virginia named Em Stevens, who was already reaching out to Bryan and Madhav and the team there to do some forecasting for flu, I believe. Can correct me if I'm wrong, Bryan. So, having that relationship there and having someone who was interested in modeling already in a key position, I think, was one of the things that led Virginia to look at the models. And then the tyranny of the urgency, I love that term, the tyranny of the immediacy, was a big part of it. So we were looking for data, looking for information, as I mentioned earlier, pulling those two different, very disparate model projections, forecasts for Virginia, and showing that to our policymakers and them having no idea what to do with those two disparate forecasts. It showed really we needed some expertise and some people who could interpret those models. Another thing I think is important is having folks understand that modeling doesn't always mean forecast models. So I think that's something that we've kind of struggled with, is folks kind of think of our modeling work as purely based on forecasting and trying to see what's coming in the future. But a lot of it is just understanding the data, doing some, mobility analysis so we can better target our vaccine clinics, and understanding the best queuing process for our contact tracing and investigation teams, things of that nature that modeling can help with as well, that kind of program level modeling. So having folks who understand the different uses of modeling as well is I think, very important. Yeah.
Thank you. So Michael Lee has a question, which I will summarize briefly by his last point, which is, what have we learned to be better prepared to deal with this next time? What mistakes did we make? What would you rather, I think, if Michael, if I'm summarizing you correctly, what have we learned about how we should have approached this, and what would you do differently? So maybe, because I haven't heard yet from Bryan, maybe we can start from Bryan to jump in and then go to others who might want to.
Sure. No, I think that's a great question. And that's sort of where we find ourselves at this point of sort of a better managed pandemic with immunity, luckily keeping cases and hospitalizations going down despite where we are in the season. And I think one thing we can do is, like, looking back, I think we found ourselves in a reasonable position, but how can we be in a better one? And I think that this crisis created, this goodwill that everyone has sort of mentioned, the willingness to sort of jump in and do things. Data that was unimaginable for previous projects became instantly available, within months. And that was really amazing. And so I think one of the things we want to do is not allow that to backslide too much. I think we have this really nice, rich hospitalization reporting. It would be good for the federal government to help support the hospital systems that do have to spend man hours to do that, so we can continue to get COVID, influenza, other kinds of diseases perhaps could also be added into those for that HHS Protect data set as a very rich and useful surveillance system. Previously, for that flu code project, we were talking about looking at state level ILI activity, which is always really hard to really fully interpret or even explain to anyone what it truly is, and whether it it varies by state about what the levels are bad or good and everything. And so it's just confusing, whereas a per capita hospitalization burden kind of is an apples to apples comparison that you can really build things on. And so I think one of the things we want to do is take this influx of data and the software products, as Ken was alluding to, try and solidify those, institutionalize those, get them into processes, try to establish ways to sustain them into the future is a key thing. And then also take advantage of the community that has been built. And I think current plans by the CDC and their Center for Forecasting Analytics, CFA, center, like they are doing a reasonable job of organizing themselves around sort of creating this sort of sustaining infrastructure at the federal level and engagement with locals. And so for those of us that are here that are interested, let's continue to look at ways to be engaged with that effort and try and, from the academic side, send them good postdocs or grad students or absorb or contribute to efforts that they're running. And I think also just staying engaged with each other. Let's not forget who the person is at our local, health place that is in charge of these kinds of things. Even if it is just a quarterly catch-up kind of a thing, I think it is important that these sort of human interactions, these relationships that get developed, sometimes you need something to feed on. So find those little mini projects where it's not as urgent as I need these numbers by next Friday, but by Christmas time, maybe we can have, something pulled together that would be a useful plan or something like that. Those kinds of small efforts, I think, are extremely useful for being better prepared in the future.
Thank you. So, Madhav, we could go on with this, but it's 3:30, and I know you said we could go a few minutes later, but I wanted to give you a chance to put your thoughts.
No, I think, Simon, first of all, thanks so much for moderating this part of the panel. I think we've probably asked all the questions that at least folks have posted here. I don't see anything else that is being posted. I'll just ask one final question to the panelists, and then we can close. And my question really is, it's a very open-ended question where I'll summarize it does, and I'd asked this in the previous panel too. And Lauren actually referred to this some. But I felt that this particular pandemic, as happens with most pandemics, is something happened. My Zoom is going to restart at the wrong time. If that happens, Simon, you'll have to take over. But my question has to do with socio-political epidemiology, a term that you, me, and Rita had been talking about. The role of social, aspects, and we talked about political part, but others could chime in, are really as important as the disease itself. And in fact, in many ways, probably a much bigger role to play, and at least we could all see this for ourselves. Do you folks have any thoughts on how we could, handle this better? I mean, I know it's a hard question, very open-ended question, but I still think you folks have the expertise to say a little bit about it.
So, I was going to sort of comment on this a little bit based on what Bryan had said. I think for me, the way I would sort of phrase it is that one model doesn't fit all, right? And I think one of the problems we have is that when you try to build many of these models, they're built at some aggregate scale, and that aggregate scale, which is trying to inform a policy, might not actually fit all of the geographic areas that you're actually including in that model, right? And so like when we built a model for Maryland actually is a pretty disparate state, right? I mean, you've got the 70% of the population lives in the core, but then there's the rural areas. And when we went and did, serology of the state, I can tell you that out in the western part of the state, we basically found no cases. And in the center of the state, or right down near DC, it was like 10, 15%, right, of people had been infected at that point. And that was, in the fall of 2020. And so the policies that you were implementing in March, April, May, and June for the entire state maybe didn't make sense to implement them in the same way in the DC area as you would in the western part of Maryland. And I think what happened based on that is that, so many of the policies were sort of one size fits all. And that led to, I think that in part led to some of the backlash. I mean, I don't know that you could fully get rid of all the political backlash, but I think some of the problems that did emerge were that the policies that were being applied because of what was going on in, say, New York and DC, where it made a lot of sense to shut down the entire state and the entire city, or shut down the city, maybe didn't make sense for Western New York or Nebraska, for instance, right? Where the case numbers were really low and you shut everything down and people are like, why is everything shut down? Nobody's dying here. And I think that some of that might be one of the things to sort of think about, because we have all these models, but there's not a lot of geographic data that's available at the levels that are important for, say, transmission, right? So we can get data like near the county level, but the county levels don't always really correspond to how people are actually interacting. And so, you know, when you're sort of thinking about how to build these models, I think it makes sense to maybe think about how some of the geographic components of it, you know, and the data that's available at that geographic component might not always correspond with the policies that you might want to implement at that geographic level.
Great. Any other
I'll-
thoughts? Yeah, go ahead, please.
I was just going to jump in and say, you know, I think the communication strategy, the marketing strategy, if you will, is really critical. Because, you know, as was just said, the message has to be tailored depending on the jurisdiction. So you need lots and lots of translators to take the science and make it meaningful. One of the slides that Lauren showed, I think, was really impactful for us, right? How do we tell a story with the data? Here's what the graph shows, and here's what we do if we decrease interactions by 50%, 75%, and 90%. That quantified the strategy for the public, for us. But it also allowed us to have a shared sense of strategy, but also an early success, right? If we do this together, if we work together, we can make this happen. And so the community for us watched that graph. They saw it going up, and as we implemented, they saw it coming down. And that had instant buy-in for the community, so that it built that trust. So using the data to tell a story that is that translates well to different communities, I think is beneficial, and certainly something that we have to embrace in the public health and academic side. How do we translate this to the community that we serve?
And I'll jump in and well, just first to Mark's point, I mean, Mark and the mayor did such an amazing job of like boosting the public and saying, hey, you know, it's up to us. We can do it. You know, we can locally flatten the curve. And then when they did it, it was like, rah, rah, we did it. You know, so they really felt the responsibility. But I wanted to return, I guess this sort of answers your question, Madhav, but I also want to return to Michael's question about like, what did we learn from this? And I think Bryan mentioned a lot of things that I would have said. But the one thing that I wanted to add is, you know, when we first went into that lockdown and all of us were, you know, hard at work using our models, I kept hearing people say in conversations, you know, this is our Manhattan Project. This is where, you know, we are going to come together as scientists and public health, and we're going to solve this, you know, unprecedented global threat. We're going to figure out how to navigate it. And like, there was no Manhattan Project, right? I mean, there was no coordination at a national level. I mean, I would say that Austin had a mini Manhattan Project where they brought all these stakeholders and they went to the scientists and the researchers, and they spent that time in lockdown, you know, thinking hard and negotiating with the state about how we were going to navigate things. But, you know, we're operating still in silos, right? Like I'm helping Austin and Bryan's helping his state, and, you know, Eili's helping his state. But, you know, and how many of us like built models of school openings, and they were probably the same models and had the same results? And how many of us, you know, and so, you know, that's a lot of redundant effort, a lot of like, you know, so I think, you know, I would have liked to have seen on a national scale, I'd like to see us build capacity for this, that, you know, the next time there is a major threat, there's much more rapid coordination, like really not just getting on calls 4 times a week, but really kind of coordinated, aligned with what the interests are, communicated down to state and local officials as we get insights and we get tools. And sort of touching on your question, Madhav, I think organically, hopefully we're going to get more interdisciplinary work that brings in experts in economic and social sciences, and, you know, so that our models account for those things. But I think, you know, as we're thinking about that, and as we're building this sort of emergence, this sort of command and control structures, plans for how you bring the scientists, that we need to be bringing the economists and the social scientists and the legal experts to the table along with the disease modelers. And we need to be on call, and we need to be coordinated at the next one.
So let me jump in on that, Lauren. It's like, if you were going to take the 5th before, I'm going to give you a better chance. Why isn't the CDC doing that?
I mean, the CDC has taken a great stride in this direction with establishing the Center for Forecasting and Analytics, right? They're really trying to build expand national capacity for data forecasting modeling. And I don't really have any visibility in what's going on inside, but from what I can tell, they're both building in-house capacity, but also trying to network more effectively and coordinate what their academic partners are doing. So I think, they may be taking baby steps in this direction, but there's also this is something I really don't know. Maybe the public health people can help with this. I was surprised at the disconnect between what the CDC was doing and our communication with them and policymaking. In Austin, the public health people were talking to the mayor and the judge, and and it seems like sometimes the CDC was a few steps removed from the decision-making. So I'm not sure that the CDC is the right level of coordination, or if it is, they have to have more direct, channels to policymakers.
But again, that question is like a policy set at the CDC level or the national level, might not have been the right policy for every state. I mean, we're a pretty large country. So even the policies in Austin may not have been the right policies for other parts of Texas at the time that they were being made.
I wasn't suggesting that the implementation stages down at the state and local levels should depend on the CDC, but I was resonating with Lauren's call for basically you and me and Lauren and Bryan all to be networking more broadly, more often.
Well, and let me just comment and say, yes, the national strategy has to allow for flexibility at the state and local level to some extent.
Sure.
And this is where we saw a big challenge. Public health in Texas has always been local. It started local, it ended local, just like any disaster. But what we saw is a transition to state preemption of local government. And that's never happened before in terms of a public health response or a disaster response. And there was some creative interpretation of disaster-related laws that were applied specifically to the city of Austin. But ultimately, it is a local problem, and there are nuances locally. There are different tolerances of risk. There are different tolerances for unemployment and impact on businesses. So a national strategy has to take into account the local nuances and has to be somewhat flexible while providing some general guidance and useful and timely direction.
So perhaps we should draw this to a close. I want to just say one last thing and Lauren mentioned this earlier. I think, at least from the time that we have been doing the work with DHS and then with Meyers and then DOD and CDC, one sense I get is people tend to forget. And I really hope that, there are not just strategies, but continued level of support in every sense, because all the tools that we have made, the networks we have built, it takes a long time to build them. It takes a very short time to essentially kill them, if I may call that, because people move on to other things, as we all have seen. And it's already starting to happen. Lauren mentioned this, others mentioned this too, people have gone back. So this information and expertise is just lost over a period of time. And I hope somehow this time we don't lose it. And yesterday, Paul Slovic said this very well. The value people might derive from a rare event that happens or doesn't happen very often is such that nobody has any incentive to sort of do this forward, defensive planning in some ways, or, he was talking about interventions. So I hope that doesn't happen. But with that, I would like to thank you all once again. It's been an incredible panel, an incredible workshop as a whole. Many of the folks from the previous round still online here. I want to thank you folks too for attending this. It's going to be very useful for NSF. Our plan is to collect this all, summarize into a report that we'll pass it on to NSF. The LEVERS project is part of the Prepare virtual organization, and our hope is that NSF will continue this effort to Simon's point of allowing us to create these networked organizations for further work as we go along, because there's a lot to be learned from sharing. So with that, I want to also thank NSF for having the audacity almost and foresight to fund this. We were funded to do this during around September of 2020 with very limited typical process that is put in place, and they had the foresight to do this. I want to thank them for continued support. So with that, thank you very much. I look forward to meeting you all in another workshop, and hopefully we can all continue the work that we've been doing for a while.
Thanks to you,
Thank
Madhav.
you. Thanks to you, Madhav.
Thank
And,
you all.